On behalf of all the co-chairs of the Mental Health Collaboration, we're really happy to have you with us today, and a very warm welcome from all of us, and warm thanks to Nicola and to Joy, who have been producing and editing this session today, which we're very grateful for. We are going to have a program today on community health worker supervision, and this follows a session that we've had a couple of weeks back on other aspects of community health work. This is very much us getting to the nitty-gritty of the work on the ground in the field of global mental health, and so this is exciting from our point of view. We want to explore best practices and strategies for providing effective, ethical, and scalable clinical supervision to community health workers, delivering a mental health care model. The session will address key questions around supervision frequency, supervisor qualifications, training, feedback methods, and how supervision evolves as community health workers grow into more senior roles. I think from my point of view, the importance of these of this is the whole question of strong supervision models in scaling quality mental health care, perhaps explicitly making a distinction between clinical supervision, which is obviously a focus on care quality and ethics, and administrative supervision, logistics, reporting, attendance, to help participants frame their input and roles. And then, of course, thinking about the actual person themselves and how they look after themselves as they go forward in the work. So supervision is very much on our mind today as we work through. Thank you very much for putting in your names and where you're from and so on into the chat. That's really helpful. And without further ado, Jackie, I'd love to introduce you to be our first speaker today. Jackie Nakazi from Nama Wellness, Uganda. Over to you, Jackie. If you'd like to unmute and go from there.
Thank you so much. My name is Jackie Nakazi. I am from Uganda. I am a clinical psychiatrist, the mental health coordinator at Nama Wellness Community Center. I am really so delighted to be part of this webinar today. And with a great passion for improving mental health outcomes, I am really looking forward to contributing to this important discussion. Thank you all.
And Jackie, would you like to make your presentation right now? Would that be good?
Definitely, it would actually do me good.
Good. Well, it will certainly do us good. Please proceed.
Okay.
Are you able to load your presentation up? Ah, yes, here we are.
Yes.
Thank you, Jackie. There we go. If you'd like to make it full screen, that would be helpful. Otherwise, please proceed. Perfect.
Okay. Thank you, everyone. I'm really so glad to present to you the supervision model for community health workers in implementing interpersonal psychotherapy for groups at Nama Wellness Community Center. Our supervision has a structure, and in our structure, we have a supervision frequency of regular sessions, which are bi-weekly, to ensure community health workers receive consistent support and guidance. We also have debrief sessions, which are weekly, and these are done for self-care, coaching, or training in interpersonal psychotherapy for groups. Our supervision format is a one-on-one, or we normally sometimes do the group sessions depending on community health worker needs or preferences. We have goals for our supervision, and one of the goals for our supervision is to maintain community health worker motivation, ensure quality of care, and also address the arising challenges in IPTG. In order to maintain community health worker motivation and quality, what normally works well with our community health workers is giving regular feedback and encouragement, also identifying opportunities for skills growth and development, and also recognizing achievements as they are implementing IPTG. Clearly, what doesn't work well is the lack of clear communication and expectations from the community health workers, and also the inconsistent supervision schedules also actually derail their motivation and also quality of interpersonal psychotherapy for groups. So the feedback mechanisms we use are quite a few. We use 3 of them. That is the direct observation, the session recording, and also the note review. And with this that we use, direct observation helps or allows supervisors to assess community health worker skills, their competences, and also provide constructive feedback. Then the session recording feedback mechanism enables the review of community health workers' performance and also identification of areas of improvement for the community health workers. We also have a note review as a feedback mechanism. This also ensures community health worker documentation is accurate and also complete in regards to the IPTG techniques. So what tools do we use for our supervision? We have 2 tools that we use, that is a checklist and also a supervision form. With our checklist, it enables a standardized supervision process, which also ensures consistency in the IPTG implementation. We also use supervision forms, which document the progress, the challenges that are being experienced in the implementation, and also the action plans. So the examples of tools we have that we use during our supervision, that is the interpersonal psychotherapy for groups, fidelity checklist, and also the community health worker supervision template. So in order to scale up the supervision of community health workers across multiple sites, there is need for training of these supervisors to equip them with the necessary skills and knowledge to be able to ensure proper progress of the implementation processes of the IPTG program, and also the regular communication to enhance our sharing of best practices and also the challenges encountered during IPTG implementation. So we have also our standardization of the supervision protocol to ensure that there is consistency across all sites. Much as we are doing the supervision of mental health, quite a number of challenges are actually encountered by both the supervisors and the community health workers themselves implementing the IPTG. Community health workers normally face challenges of managing the group dynamics, which is actually something quite very common with almost every groups that are really implementing interpersonal psychotherapy for groups, and also maintaining participant engagement. So with the supervisors, we also encounter challenges stemming from addressing a community health worker burnout and also motivation itself, and also balancing support of these community health workers and also maintaining integrity of quality control of the IPTG processes. So this is a call to action to every implementing partners for every organizations that are doing interpersonal psychotherapy for groups or working with community health workers, that there is need to prioritize community health worker supervision or the counselor supervision to ensure high quality interpersonal psychotherapy for group delivery. Thank you all.
Thank you very much indeed for that. The call for action is noted, and I can see people already getting ready to manage that call for action as much as possible. Thank you so much. That was really interesting and will give us plenty of discussion points in the breakout, which we're going to have in a minute, after we have heard from our next speaker, Ana Claudia Andrade. Ana Claudia, very warm welcome to you. Please come on board and let's hear your presentation.
Thank you so much, Chris. Thank you all for this invitation. Let me share my screen to start my presentation.
Sure.
Yeah, everybody sees my screen?
Yep.
Yep. So again, as I said, thank you so much for the invitation. I'm Ana, I'm a clinical psychologist from Brazil, and I have been working in this field for many, many years. Today I'm going to be talking to you about interpersonal group therapy for women and youth that are depressed. And this work is done by Restore Hope in Liberia. We started, okay, why this is not going? For some reason, I am clicking on it and it's not going. Do you see my screen moving? Yes?
Yes. Yeah. We
Okay,
see
good.
program
Okay.
overview.
Okay, it went now. Okay. So as it says there, our program started in 2020, and I had the privilege of being the trainer back then and still, involved in the program now. So it has been great to see the development of this program in this past 5 years. Restore Hope Liberia is the only organization in Liberia implementing IPT, which you can imagine brings implication on the lack of expertise inside of the country. So we have been working a lot with capacity building inside of Liberia so that the work can keep going. At this moment, we have 19 lay counselors and 1 mental health manager. The clinical supervision is delivered both in the field by the mental health manager, and then I give him supervision remotely. So we do supervision of the supervisor remotely. And depending on the level of the training, we deliver remotely the supervision. So right after the training, when they are still under their first and second group, we deliver direct supervision to the team remotely. And then they move on into being supervised by the mental health manager locally. We do supervision in 2 manners. So the mental health manager, he supervises the facilitators in 2 ways, in a weekly group meeting that is divided into parts. Like Chris said in the beginning, we have these managerial aspects, logistics to make sure everything is going well. And then there is also the clinical aspects where they discuss everything that they need to discuss to make sure that fidelity is ongoing. The mental health manager does in-person observation of the groups. He gets consent from the clients and he goes into the groups to sit with them and observe the group's dynamic. And then right after that, he will sit individually with each facilitator and give them feedback based on these tools for supervision that we use. Very similar to what Jackie said, we have our checklists depending on where the group is. There is a checklist for the initial phase, a checklist for the middle phase, and another checklist for the termination phase. And the facilitators deliver weekly notes. And as I mentioned before, we do this remote supervision of supervisor. That is me meeting Stephen, who is our mental health manager. He is a physician assistant with a lot of years of experience in clinical work. So I then discuss with him weekly, how his supervision is going with the facilitators. What has been working for us is doing in-person training, and not just an initial training, but also refresher trainings to make sure that we build rapport, that we build motivation, and that we keep the skills going. As I mentioned, we have weekly group supervisions to improve fidelity. We developed a buddy system where we pair up, like weaker facilitators, the ones that we feel that need some support, with the stronger facilitators. So that's like a buddy system. We also feel that we have stronger outcomes when the manager himself has IPT IPT skills as a clinician. So we make sure that he is also an IPT practitioner. And as I mentioned in the beginning, we are focusing a lot on building capacity of facilitators to become assistant supervisors to really build internal capacity of our workforce. The challenges we face, I would say that the major one is our turnover. We have turnover both in the management position and in the counselors' positions. We work in a very remote, in a difficult location far away from the capital. We've stretched resources and a heavy workload. So as you can imagine, that makes our turnover happen with the management position. And the lay counselors, most of them, you know, they have other priorities. They have other jobs, or they have big big families, and then it's always a competing priority between, you know, working with the IPT groups and making sure that it goes well for all their priorities. So sometimes we do have some turnover there as well. Another challenge is the low literacy. To document weekly has been a challenge for some of them that don't write very well the notes. They can do a very good job when Steve goes and watches their sessions, but with the notes sometimes are weak. The remote supervision can limit engagement sometimes when I am doing the supervision remotely. I can hear some noise in the background. Okay, it's good now. And then, of course, this layered supervision, when I supervise a supervisor, it adds the cost, right? So the cost per client increases with this model. And hopefully when we build enough capacity internally, that model is not going to be needed anymore. But for now, that's the model we are using. And because of this turnover, it causes gaps, right, in our team. So the gaps in supervision leads to a reduction in their motivation, and sometimes even like a struggle to continue their growth as clinicians. What we are changing is, you know, to try to work with their difficulties in writing. We are trying now some audio-based supervision notes where they tape their notes. We are building a pipeline of supervisor assistants. So we are trying to identify, you know, who are the facilitators who have a strong performance and can eventually become supervisors. As I said, the manager maintains at least one clinical case, and sometimes he runs groups as well to make sure that he maintains his clinical skills. And developing this career trajectory for the counselors, you know, is something for them to look forwards. I'm a counselor now, but I can become an assistant supervisor, a manager. So there is this trajectory that we are trying to build. We are also working on hiring some full-time among them. Not all of them can go full-time, but for consistency, we are going that way with some of them. And of course, we are investing in a TOT model because we know that that's key for scaling, right? We can't keep bringing people from outside to train. So we have had an experience with 2 local managers training group of facilitators, and I just supporting them remotely, which actually worked very well. So to finish, I would like just to talk about our AI tool. This is a project that is ongoing. So if we have interested partners here, by all means, let's connect. We have the email there. It's an IE tool in ChatGPT where the facilitators can go and practice seeing a client online, right? So they see this client and then they receive some feedback from this AI supported tool. So I think that that's it. I tried to be as fast as possible. Thank you so much for listening to us. And here is our contact. Please check us out. Thank you.
Thank you, Anna, very much indeed. That's wonderful. What a wonderful set of presentations we've had already. We could just go home now, but we're not going to. Joy, would you like to take us through into the next section? Would you like to introduce that? That would be really helpful.
Sure. What we're going to do now is a brief section of breakout rooms in which one of the team members will be kind of guiding the conversation, but really what we want is for this to be an opportunity to learn from everybody else in the room. We know that there's a lot of experienced practitioners, and so this is a chance for people to share their experiences and also just kind of share some of the challenges that you might be facing in your own program.
That's great, thank you. And so I think, Susan, are you ready to
So-
whiz us off?
We'll be spending
Yes, 30 minutes in the groups, right?
Yep, great.
That sounds terrific, yeah.
Sorry, Anna, you got cut off. My group was amazing, just to say, Chris.
I'm delighted to hear it.
Undoubtedly due to your amazing facilitation.
No.
I'm delighted to hear it, but my group did very well too.
My group did as well. It was just all around A+ for the groups, obviously.
I'm sorry, I dropped out of Chris's group and went to another group.
So you can actually have the objective comparisons.
I wondered where you'd gone, Pauline.
I went to another group.
Spy on that.
It was
Well,
amazing.
I just want to, I mean, our group, we actually solved mental health. We have fixed the problem.
Oh, wow.
Yeah, that's the kind of group we were.
Oh, well, in
that's
that case, we can all go home. It's fine. We can go yay, like this. Yeah. So we've got a few minutes for discussion. And is anyone would like to drop in some discussion points at this? You're very welcome. I noticed that a lady, Laura Castro, you'd asked a couple of questions on the chat earlier, and I was going to suggest, Jackie, that you have a look at those questions and maybe try to answer them offline because they're quite specific to your presentation. But it would be important, Laura, for you to put your email address in the chat, please. And then, Jackie, if you would like to have a look at those questions, copy and paste maybe, and then take her email address, then you can have that offline conversation with Laura, which would be, looks like it will be helpful to Laura, which would be great.
Okay, then, very great.
Great, thanks, Jackie. Anyone with a question or two before I start to wrap up and sum up? Wonderful to see even more people here than when I left. So that's great. Hi, Gabriella, good to see you. And lovely to have you with us, Kavita. And many others. Good to see you, Sue, as well. Thank you for coming. Any other thoughts and questions while we're in the big group? I have never seen such a satisfied group before. Everyone is completely satisfied with everything that's been said.
Chris, can I just mention that, one thing that really caught my attention, in our small group is the amount of digital tools that are being employed in supervision. And I think this is an amazing topic. And, just as a suggestion, maybe we could have, a meeting where we would, dig deeper into tools and what is being used to what extent and the successes and failures of it.
That's great, a great idea. Thank you for that, Anna Claudia. Ursula, do you agree with that?
Yeah, I was just going to put a message. That's a great suggestion. So we'll definitely take that on board.
Right.
Thank
I
you.
think my colleague Lauren Magoon is with us somewhere. So that would be it. She would be a very helpful person in that context. Are you with us, Lauren, or did you have to jump off again?
And while she's answering, Comcare came up very loudly and clearly in our group, Lauren. So hopefully she's here.
That's good. Oh, well, that's good. If she's not here, then we can tell her.
Yeah, we'll
When-
tell her.
We will tell her.
But we did say it was, as Anna said, interesting just how much people are shifting to digitized approaches. And we agreed, a couple of us are using chatbots, using AI, but also just in kind of more routine, the supervision process. So we were saying it would be really useful to have further talks on that.
Yes, absolutely. Brian Renzi brought this question of AI in supervision into our meeting, and Brian, I'd encourage you to re-put your email address into the chat so people can pick it up if they like to talk. Laura, do come in.
Yes, thank you, Chris. So I have a lot of questions because we're just starting to build all of these systems in my NGO. And one thing I would love to see if this amazing group wants to put together is a kind of like repository of all of the different checklists or maybe supervision guides that you all have built. I think having that in a place where we can look for inspiration of how to really build that well would be super useful.
Absolutely. I've been working with an organization called Health Leads USA. Alexandra Quinn is their chief executive, and we are thinking about a repository very much in the same way that you've been thinking. So if people are interested in that, do drop me a line, and I'd be happy to make sure that I guide you towards whatever we're thinking about at the moment. Don't forget the Mental Health Innovation Network, MHIN, is also a good repository in the sense that it's a good information source. And that would be also that.
Also, if anyone does want to add that there's the document for the breakout rooms, if anyone wants to put any specific links or resources in there, what I'll be doing afterward is creating a summary of sort of the collective knowledge. And so any links that are put in there, we'll make sure that gets sent out, and that'll be emailed to everyone who's registered for this event today.
That's great. Joy, would you like me to do a bit of summing up now? Because otherwise we'll start to lose people.
I think we're about at that time. Yeah.
Yeah, we are. So Joy, first of all, let me just, on behalf of Ursula and myself and other co-chairs of the collaboration, just want to thank you, Joy, and thank you, Nicola, for bringing this particular series to us. We really appreciate it very much. Jackie and Anna Claudia, thank you so much for your presentations, which have sparked off conversations in the various chat rooms, which have been fantastic. This is not a session which is particularly sensible to sum up in great detail. Otherwise, you just repeat everything that people have already said. But I think what is important to say, a couple of things. One is the quality of the supervision, meaning who supervises the supervisor, is actually quite an important issue. And then the supervisor going on down to the next cadre below, different names for that next cadre, but facilitators or whatever they may be called, I think is very important. And trying to establish in a qualitative way what essentially comes out as a quantitative success is also quite important. In other words, if you have the ability to be able to assess across many people by being a good supervisor, in quotation marks, and if you are able to, perhaps through a mixture of group supervision and individual supervision, if you are able to bring about that qualitative approach to the beneficiary or the client themselves, then what happens is that you do get this uniformity of approach, you do get this uniformity of quality, which I think is very important indeed. That to me was one of the sort of things that came right off the top of everything that we were talking about. I have a feeling that some of the people here would rather like to have another session, Nicola and Joy, at some point. And I think that would be very important. We've already given some direction towards the idea of having a session around digital work, digital accumulation, digital supervision. And some people, by the way, talked about that. When they talked about recordings and they talked about the use of handheld machines and so on and so forth. So there is quite a lot of information there already. But I think we would like to do that. I wanted to just wrap up by saying the mental health collaboration of Catalyst now is really pleased to have welcomed you all to this session, and we will send a copy of the recording to everyone who is here. That'd be fine. And Joy is very kindly going to put together a summary of what was discussed in the breakout which is also great. Thank you very much for doing that. I hope you can read my writing. No, it's fine. So many, many thanks indeed, and we look forward to seeing you soon.